So here is our roadmap for today. First, we'll see why it's about way more than just weight loss. Second, who actually qualifies. Third, the rigorous pre-op checklist. Fourth, the types of procedures out there. And finally, the real risks and complications.
All right, kicking things off with Section 1, more than weight loss. We really have to completely reframe how we view these procedures, because they are absolutely not just cosmetic tools.
The absolutely crucial point here is that this is actually metabolic surgery. It fundamentally alters your body's internal chemistry to treat some seriously deadly conditions, things like type 2 diabetes, high cholesterol, and hypertension. It also addresses severe joint pain, which is the most common problem associated with increased weight, and it can even reverse dangerous sleep apnea. So this isn't just about the number on a scale, it's literally about extending your lifespan.
And this right here brilliantly illustrates why those extreme crash diets almost always failed. When you severely restrict calories, your body kind of panics, right? It ramps up ghrelin, which is a hormone that drastically spikes your hunger. Metabolic surgery, on the other hand, physically alters your gut's hormonal pathways. It permanently drops those hunger-driving ghrelin levels while simultaneously boosting satiety hormones like GLP-1 that tell your brain, hey, we're full. It's a literal rewiring of your biological and genetic drivers.
Moving on to Section 2, who qualifies for surgery? Now, what I found really surprising when digging into this is the strict, cold, mathematical criteria you have to meet to even be considered. The rules are incredibly rigid. You can't just walk into a clinic and ask for this. As a standalone indication, a patient must have a body mass index over 40. If they have obesity-related complications, like diabetes, that threshold drops to a BMI of 35. But notice this really important distinction for Asian guidelines. They drop the required BMI threshold by exactly 2.5 points across the board. You absolutely must meet these precise numbers.
However, surgery is completely off the table for certain patients. This includes folks lacking the motivation to change their dietary lifestyle or those with Prader-Willi syndrome. This is a genetic condition where literally no surgical intervention can curb the physiological instinct to eat. No matter how much a surgeon shrinks their stomach capacity, they will constantly feel starving, which makes the surgery entirely ineffective.
All right, Section 3, the pre-op checklist. Let's look at the incredibly rigorous preparation phase required before a patient ever even sees the inside of an operating room.
Patients literally have to survive a strict gauntlet managed by a huge multidisciplinary team. Weeks prior to surgery, they have to stick to a brutal liver shrinkage diet just to make the operation physically safer. If they can't stick to it, the surgery is paused and they go work with a psychotherapist. They also absolutely must quit smoking to prevent wound infections. And if they have sleep apnea, mandatory oxygen therapy is required to prevent really dangerous post-op complications like deadly surgical leaks.
Section 4, types of bariatric procedures. We're heading into the operating theater now to rapidly break down the actual surgical interventions available today. So, looking at this surgical showdown, procedures like the duodenal switch offer maximum weight loss through extreme malabsorption, but their nutritional complications are so severe that they're rarely performed anymore. That leaves the Roux-en-Y gastric bypass as the most acceptable overall procedure, because it combines restriction and malabsorption. Meanwhile, the sleeve gastrectomy, where they physically remove a huge portion of the stomach, is currently the most commonly performed procedure worldwide.
150 centimeters. That is the length of the intestinal bypass limb used for super obese patients to massively increase weight loss. To give you an idea of the extremes we're talking about here, there's a famous case of an incredibly heavy Egyptian woman who traveled to India for this exact bypass. She was so severely obese that it required literally 2 cranes just to lift her safely into the hospital bed.
Now, for those wanting completely reversible options, gastric bands and intragastric balloons offer restriction that can literally be adjusted or removed. A band is placed around the stomach and inflated with saline, though I should note this comes with a really high risk of the band slipping. Alternatively, balloons are inserted purely endoscopically to create a temporary feeling of fullness. These are wildly popular for patients trying to drop weight right before major life events, like a wedding, because the balloon can simply be deflated and pulled right back out.
For patients who refuse surgical scars entirely, surgeons utilize these mind-blowing NOTES procedures. Think of a patient who actually stretched her stomach back out by constantly drinking carbonated sodas. When she regained the weight, she completely refused another abdominal cut. So using NOTES, a surgeon inserts an endoscope directly through the mouth and physically staples the stomach walls closed from the inside. 0 external cuts, 0 scars. It's amazing.
Section 5, real risks and complications. This brings us to the realities of surgery, and honestly, our most sobering chapter. Because despite the miraculous outcomes, this is absolutely not a risk-free journey.
Surgeons rigorously calculate mortality risk using the OSMRS score. Patients get points for being over 45, being male, having a massive BMI, or high blood pressure. But what completely blew my mind during my research is what is missing from this list. Diabetes mellitus is notably and deliberately excluded from this mortality scoring criteria.
Tragically, as seen in the super-obese Egyptian patient we just talked about who sadly passed away shortly after returning home, deep vein thrombosis and pulmonary embolisms represent the absolute leading cause of death post-surgery. The risk for fatal blood clots in this demographic is just astonishingly high.
Beyond blood clots, surgeons battle terrifying complications like internal bleeding and leaks where the stomach was stapled, specifically the highly distressing leak from the angle of His in sleeve surgeries. And nutritionally, the fallout can be severe. Iron, vitamin B12, and calcium deficiencies are incredibly common. Most terrifyingly, patients who experience persistent vomiting and skip their daily vitamins can suffer irreversible brain damage, a condition called Wernicke's encephalopathy, caused entirely by a simple thiamine deficiency.
So, we really have to ask ourselves, if a patient survives the strict guidelines, the extreme anatomical rewiring, and the terrifying complication risks, are they truly prepared to accept that this life-saving surgery is actually just day one? It demands permanent dietary vigilance and a lifelong partnership with a medical team. It's a miraculous tool, without a doubt, but it leaves you wondering, is the physical surgery actually the easiest part of the entire journey?